Hi, everyone, and welcome to the first Y.E.S series of 2025, and Happy New Year. My name's Amy. I work at the North Suburban YMCA. Part of the Y.E.S series, just so you know, is it's a completely free educational series that is available for everyone in our community. We are located in Northbrook, Illinois. If you live in the area, please stop by and visit us. Today we have Denise Schwartz. Denise Schwartz is a licensed physical therapist. She works out of the Manual Touch. Denise works on a more holistic approach to help her patients kind of pinpoint their issues and how to help them through their pain and navigate that process in a natural way. And today I'm excited because we're going to be learning about how to heal neck pain in a natural way. And with that, Denise, I'm going to let you take it away.
Thanks, Amy. Welcome, everyone. Happy New Year. I am going to share my screen, so give me a moment while I get set up. Okay. All right. My mouse is still there, right? The little arrow.
Yeah, I
You
can
guys
see
see
it.
it? Okay. Another little housekeeping thing. If you have any questions, please put your questions in the chat box or save them for the end, and we will go over that at the end. It's hard to, I've hid in everybody's face, so I can't see anyone, including myself. So I won't see if there's a hand raised or anything like that. So go ahead, and if you have a question, write it down either in the chat box or on a piece of paper and let us know at the end. Okay. Well, welcome everyone. Happy New Year. Thank you for having me, Amy. I've been doing these talks now for many years with the Y. I don't remember when we started, but I think we're going on like 7 or 8 years. Quite astounding. And today we're going to talk about neck pain and what you can do to heal it naturally. Okay. As Amy said, I am a physical therapist and the owner of the Manual Touch Physical Therapy in Wheeling. We use a whole body approach of traditional and non-traditional therapy to get people back doing the things they love to do. So let's say, well, there, I kind of missed it. You want to get back to doing some of the things you love to do. Here, I'm on a kayaking trip, or actually, wasn't a kayak, it was a kayak day in Alaska. So maybe you would like to get back to doing some travel, or you want to get back to golf and your neck pain is limiting you. Again, some travel, or you just cooking is a problem, or hanging out with friends. Or maybe you want to do something really exciting, like these 3 ladies who I met when I did the Gasparilla Half Marathon in Tampa many years ago. These 3 women all had already walked the 5K. They were going to walk the 10K and then the next day do the half marathon. So they were quite something. But maybe it's just something as simple as just getting your back to hanging out with your friends and just doing everyday things. When I got out of school many years ago, I knew that low back pain is the #1 reason people go to see their doctor. So I took many classes to become an expert in treating back pain. And of course, along the way, I took lots of classes on how to treat everything else in the body, and really looking at people as a whole person. I became very good at doing some very good traditional physical therapy, getting people better. But I did find that there was a population that didn't respond very well to that. And as I started learning a non-traditional hands-on approach called integrated manual therapy, I found that I could help everyone with this piece, particularly people who don't respond to traditional therapy or medical care. I then left the hospital. I used to work at Lutheran General Hospital for 14 years, and then I left there and worked for the company that did this non-traditional work for 7 years. And then we parted ways in 2010, and I opened up the Manual Touch Physical Therapy, and I combine the non-traditional with the traditional therapy, because I found that there was a lot of good stuff in traditional therapy and getting them people back to doing what they want to do. In addition to that non-traditional and traditional hands-on approach, which we call manual therapy, I look at people as a whole with movement. So I use something called applied functional science to find out where in their body is limiting them from healing and movement correctness. Okay. I have a certification in that. And then a few years ago, I added in the OOV and balance sit that I'm going to talk about later. And then I do have a nice subspecialty working with runners. We do a running analysis. That's my son. I'm videotaping him on the treadmill. But today we're going to talk about neck pain. And specifically, I want to talk about the 4 common causes that I see in my clinic. Obviously, there could be lots of other reasons that cause it, but this is what we see most of the time in physical therapy. We're going to talk about anatomy and what's really going on and some tips on what you can do about it. So the 4 common causes are arthritis or stenosis in the neck, the cervical spine. That's your neck. Stenosis is a narrowing. And it could be in the spinal canal or in the foramina, and I'll point that out in a moment when we do anatomy. The next most common cause would be a herniated disc. And then probably the most common, particularly with younger people, it's really just a musculoskeletal issue. They have postural weakness going on in their back, in their neck, people who sit all day long. Everything is just gotten weak, and so their neck has to work too hard to hold them up. What I'm noticing a lot, people who actually don't breathe really well through their diaphragm, and they tend to use the muscles up here to breathe. And so they get soreness because they're overusing these little muscles that aren't really designed to breathe for you on a continuous basis. And then there's people who I call, it's still a musculoskeletal, but it's more of the bone alignment. So people with scoliosis, or they've actually strained a muscle in their back, and there's an immobility, or things get kind of locked up in the spine itself. So we have to kind of get some better joint play there. So people with neck pain or a neck diagnosis often have one of these complaints or all of them. They might have head pain, neck pain, arm, upper back, the shoulder. So you can have arm symptoms and it's actually coming from your neck. So it's really important for us to discern, is it actually coming from, let's say, the shoulder joint, or is that achy shoulder pain that's going into the mid upper arm is actually coming from your neck? Hand numbness, tingling, or you say that your arm falls asleep. The biggest complaint, of course, is people can't turn their head or move their neck as much as they used to, and it always feels tight at the end. So it always feels tight. Sometimes people have headaches or vertigo. If there's really a pretty significant something going on in the neck, then they might have some weakness in the arm or hand. And then you have just difficulty functioning, everyday things, sleeping, driving, walking, working on the computer, doing your hair, can all trigger any or one of these symptoms or cause pain. This is an ebook that I have. If you would like me to send it to you, go ahead and put your email in the chat box and with your first and last name, and I will send you this ebook on some tips on how to take care of yourself on a daily basis. All right, so now for the exciting stuff. Understanding the anatomy of your neck and how it interacts with everything above and below it can be very helpful to knowing why you have what's going on. So this is a side view. This is your head, your skull, obviously. This is your neck, known as your cervical spine. These are all the vertebrae, and there are 7 vertebrae in your neck. And then you hit the thoracic spine, there's 12. And then the lumbar spine, there's 5. And then below that is your sacrum, and then your coccyx, and this is your pelvis. This is the back view. So if you're looking at someone's back, this view here is inside your body, and in front of your spine are all your organs and so forth. I think, yeah, in the next video, you'll see how the ribs play a role in here. You can kind of see in this one, but not very well. The spinal cord comes, attaches to the brain, and it comes out through a hole on the bottom of your skull, and it goes down between all the vertebrae all the way down. And then there's a nerve that comes out between each segment here. I have a picture of that coming up. And on the front, on the inside, this is called the vertebral body of each vertebrae, and in between each body is your disc. This is obviously the front view, which we call the anterior view. I wanted you to see how your rib cage comes all the way up to here. So let's see, it attaches here. The first rib attaches to the first thoracic vertebrae, and it's very close to the last cervical vertebrae of your neck. So this component here can play a big role in being a problem. Some people are like, oh my God, that's my first rib, but you forget this rib cage starts all the way up here in your neck and then goes all the way down to above your abdomen. And here you can see how the discs are in between each vertebrae. Oh, actually here, this is actually a nice view. You see this hole? That's actually called a foramen. Any hole where a nerve comes out is called a foramen. We have lots of holes in our head up here where there's nerves that come out through, and they're called foramen. But the ones we're concerned with is the nerve coming off of the spinal cord through the foramina out of the vertebrae, and it goes down to your arms. Here's a little bit better picture here. You can see how this yellow is the spinal cord coming out attached to the brain, and then in between each segment is a nerve, okay? And where it comes out between the segments is called your foramen. So I do see a lot of MRI reports talking about foraminal stenosis or arthritis, a narrowing of here, this foramen, and that's how that nerve gets impinged. So sometimes it's of the canal in near where the spinal cord goes through, and sometimes it's through the foramen there. There's another view. If you kind of cut someone down the center here, and you cut off half of the vertebrae, you can see how your spinal cord comes down. There's the back end of the vertebrae, and this is the inside. And you can see if you had a disc, if it bulges, it can hit the nerve coming out through the foramen. This disc is like a jelly-filled donut. On the middle part of the disc is a nucleus, which when it gets injured, it can bulge to the outside of the disc here, which then compresses on a nerve. Wanted to show this. I didn't show a picture of all the muscles that go into the neck because it's a little overwhelming. But what I want to let you know, I remember I mentioned about people who breathe up in here. They tend to get these little muscles here. So anybody who might have asthma, COPD, or emphysema, they don't get good breath expansion using their diaphragm and their lungs. So they wind up using these muscles up in here. And you know what? That can cause neck pain. I see that a lot with people, particularly when there's really no other significant reason why they're having pain. It's often because these little muscles are being overused. These muscles, which we call the suboccipital muscles, because this is the back of the skull is called the occiput. This is the occipital bone, and underneath that, there's the occipital lobe of the brain. So we call these the suboccipital muscles. And these little teeny muscles do an amazing job. What they do is they stabilize your head on your neck in relation to where you're looking, and where you're moving. So it's always firing depending on what you are doing above or below. So when you move your eyes, these fire, so it stabilizes your head, so you stay upright and you can see clearly. So these interact very much with your vision, your brain, your inner ear, and all the other bones and muscles below to help keep you in balance. And in fact, this area really tells your body and your brain where you interpret where you are in space. So it's very important to get these muscles working as optimally as possible. And so we have some tools here for that to help you with that process. All right, so what do we see when someone has an arthritis, stenosis, or an impingement in the spine? And there's a lot of overlapping symptoms that people will have. Um, so people who just have arthritis, and they don't have arm numbness or any arm symptoms, but they have pain at the end range, like, oh, it's just tight, or it's achy, or creaky, or crunchy. Um, Oftentimes it's just arthritis. Um, Stenosis you might have some neurological symptoms in the arm. When you get numbness, tingling, or weakness, or decreased reflexes, that's a neurological sign. We can help you in physical therapy, but sometimes it's too bad that we really got to get you to the surgeon. So we really can distinguish between when surgery is appropriate, when it's not. More often than not, people do get better with doing therapy. Um, Maybe your arm falls asleep at the end range, and that could be an arthritis, so the arthritis is a buildup of bone, particularly in that foramen area, and then it impinges on the nerve coming out. And sometimes, when it's stenosis, especially in the canal, you might have some symptoms on both sides. But that's more common in the lower back, in the lumbar spine. When you have stenosis, you feel it in both legs. In the neck, I still see it more one-sided, and I'm seeing more and more that it's more of a foramen stenosis as opposed to in the spinal canal. I think when people get stenosis in the spinal canal, it's a more dire situation. And so I don't know if I see that as much as I see the foraminal stenosis. A herniated disc, we'll usually see that in people younger. Younger could be up to age 50 or 60. You get one-sided numbness, tingling, weakness in the arm. Um, Arm falls asleep, loss of mobility in the neck, meaning, you just can't move as far as you used to. There might be a decrease of reflexes. I would say here certain head positions reproduce the arm symptoms. This could happen with the foraminal stenosis or a herniated disc. Every time you look to the left, I get pain down the arm. If I look to the right, I don't have pain down the arm. So that's a reproducible symptom and that we look for, and kind of discern, obviously something's being impinged when a movement is causing pain or symptoms down the arm. A skeletal or the soft tissue issues are the easiest things to take care of. Here, I get people, I'm like, I slept funny and I can't move my head and it hurts a whole lot. Oftentimes that's what we call an elevated first rib. If you remember where that first rib is up, it almost actually in your neck region here, that rib, it's kind of like getting something stuck in your tooth. And until we can kind of get that thing out of the tooth, it won't feel better. The elevated first rib is where the muscle up here might spasm and the rib kind of shifts just ever so slightly on that first thoracic vertebrae. And it just doesn't mobilize the way it's supposed to when you move around, and it's just literally stuck. And the only way to fix that is to get in there and to mobilize that joint so you get normal joint play in there so it can function the way it's supposed to. Um, Similarly, someone gets a rotation in the cervical vertebra. You get kind of a spasm in the neck, and the vertebrae might rotate and just get kind of stuck there instead of moving with you. You can get that in the upper thoracic spine as well. I see that a lot. People turn their head and they don't, you should move all the way down into your thoracic spine, and they don't. So we got to get better joint play there as well. When people get really locked up in there, they might complain of jaw pain or ear pain. And so we have to discern, is it actually coming from your jaw or is it coming from the cervical vertebrae? If we look back here, here's your jaw, and you can see how close it is to the top of your spine. So there's a very big connectedness, um, connection between these areas that one can lead to an issue with the other, or vice versa, or you get radiating symptoms from one or the other. What else? Oh, people might get headaches or migraines. And it's actually coming from limited joint movement in their neck. Or they might get what we call cervical vertigo. I mean, the technical term is cervicogenic, meaning your vertigo is actually coming from poor alignment and movement in the cervical spine, as opposed to coming from the inner ear, the vestibular system. Um, so, and that goes back to these little guys here. If they're not doing their job, then, you know, maybe you turn around quickly, or you look at something quickly and these guys don't respond, and then they're not talking to your inner ear and you get dizzy. So a lot of dizziness often comes from here as opposed to the inner ear or the brain. But that case is a different topic to discern whether it's brain, inner ear, eyes, or upper, or the neck, or actually coming from even further down the chain. Soft tissue issues. This we see a lot of, particularly postural weakness. And I would say everybody has this. But sometimes you just have this weakness, but you don't have the significant issues going on in the spine itself. Your muscles have gotten weak. Particularly people who are like, oh, my neck is sore at the end of the day, or when I look down and read for too long at the end of the day, or their balance is a little affected. And that's really about getting you stronger in your core and building you up from below, so your neck has a strong base to sit on. Also, we might do something from the top down where we start really getting these upper muscles up in there to integrate. So we do a little bit of compression through your head as well. Those of you who've had the unfortunate experience of having rear-ended, where you might have a whiplash injury, and that's where, you know, you get hit from behind and your head goes forward and your head snaps back suddenly, and you strain the muscles in the front of the spine. So those would be neck muscles sitting here in the front. Okay. Other soft tissue, we talked about respiration, people where they overuse what we call these little muscles in here, and we call them your accessory breathing muscles. They also do other things, you know, they turn your head and, you know, but this will help. Sometimes people use this instead of their diaphragm, or they use this more than the diaphragm. You might still have neck pain or arm pain, but that arm pain isn't necessarily coming from something going on impinged in the spine. It still could be a soft tissue issue impingement. People might have upper back pain, and it might radiate up into the neck. So they think they might have in the neck, but it's actually coming from down below. In fact, I had a couple people yesterday. Their primary complaint was mid back pain. And then, oh, by the way, my neck is kind of stiff. I wonder if it's connected. Well, it is. So just like I talked about in a skeletal issue where one of the vertebrae is rotated in the neck, these two people had a rotation in the mid back. And so if you can imagine, if something is kind of turned down below and there's soft tissue or muscles climbing up, so you got a rotation here, the muscle here that kind of comes all the way up here is going to be pulled kind of taut. And so you're going to, and then you go to turn your head one direction and it doesn't go so well because this isn't in a good position. You'll get neck pain. Hopefully that makes some sense. That kind of tells you, where did I? Everything is connected. Okay, so it doesn't matter what you're doing. If there's a problem somewhere down here, you could feel it up here. Think of a garden hose. The water isn't coming out the one end. You're not just going to keep playing around with the little hole at the end and why the water's not coming out. You're going to look for where is the kink along that hose that's causing the impingement, not letting the water to get through. Same thing with your body. Okay, upper back and invasive skull pain. We talked about that a little bit as well. All right, so if we got postural weakness or immobility, I talked about weakness, but immobility. So again, if somebody can't move their ankles well, so then they don't move their pelvis as well or their back, then they overuse their neck, or they overuse their mid back. And that's what happened with these couple people that I saw yesterday in they had this upper back pain. The one fella, he was he was what's it called? Surfing behind a boat. He was on a surfboard behind a boat as opposed to water skis. And I guess he turned, and he kind of locked up in his upper back, and he's had problems there for the last 6 months. But in taking a look at him, in addition to this being kind of stuck here, the reason that happened to him was because his ankles didn't rotate enough. So then he pulled through here, um, tried to over move through here because down below didn't move with him. Okay, so that's an immobility piece. And I see this a lot. People don't move their hips very well, particularly their ankles. I know it's very far from your neck, but as people get older, particularly men, their ankles become really rigid and stiff. And because of that, um, you wind up moving, you have to move somewhere else, and or your balance feels off. And so everything becomes more rigid up above because your ankles can't support you the way they need to, or they don't adapt to the moving space underneath you. And as a result, everything becomes rigid and tight. So everything's not moving. And then somewhere you get pain, and oftentimes it's in the neck. This is a wonderful little graphic I found that I fix people every day. They come in. We all seem to bend backwards here for some reason. Okay. I think my theory is, as you know, particularly as we get older, things just shift around. Our vision, we can't see, we have to look differently through glasses. Our spine changes, and as a result, somehow we lean backward too much. And so I'm often telling people to not lean back as much here and to kind of lower your chest down. So at the very least, that's tip number one. This clue that our moms all gave us to throw your shoulders back and stand up straight, you got to kind of don't do that. You don't want to go back as far. You want to just lower your chest down a little bit, because what happens is when you throw your shoulders back too much or too hard, then these muscles get overused, and then you get pain back there. So just relaxing your chest here, allowing these tissues to relax, will make a big difference. Working on your core. Your core muscles are everything from your diaphragm down to your pelvic floor. Those people who sit all day long at work, and they're kind of hunched over, these muscles and their butt muscles kind of turn off. And as a result, the neck has to work too hard trying to stay on top of something that's not stable. So more often than not, particularly with chronic neck pain, we have to really get this working better and get you in better position, postural alignment before that neck pain is really going to settle down. So getting massages just on your neck may not do the trick because we're missing the bigger component of the loss of mobility down below and the weakness from down below. So these are just examples of how you can see if your posture's spine changes, how your head and neck has to adapt to all those different places and can cause a problem. And, one little rock goes out of place, this whole thing topples over. And again, we talked about everything's connected, the same thing here. Okay, so how do we know when we need to get to a surgeon or physical therapy? More often than not, if your symptoms are reproduce or you need to get to a doctor, if your symptoms are reproducible, I turn my head this way, my arm goes numb. I turn back here, it goes away. That's reproducible. If I sit too long by the end of the day, my neck hurts, but in the morning it's not so bad. That's reproducible. When you've got constant neck pain, no matter what you do, and you can't move or find a comfortable position, that's usually not reproducible. However, I do find when people have that first rib, and that's like, oh, I woke up and I slept funny and my neck is just stuck. You're just achy all over and you just can't, nothing takes it. I've had it myself many times. So that really, and that doesn't respond well to when it's that first rib stuck, it doesn't respond to ibuprofen. Maybe pain meds will take the edge off, but until we can get kind of like getting that thing stuck out of your tooth, it's not going to go away until we get it shifted. So I think in this case, it's a little different than the reproducible that for other parts of the body. Here's some people who had come in and got better and wanted to let us know. So if you, again, put your name in your email in the chat box, I will send you this PowerPoint and you can read all about how people got better. So what's the biggest mistake people make with neck and arm pain? They ignore it. I think it'll just go away. I'll just get better. But the sooner you kind of come in, the sooner we can kind of take care of it. Here, I was in Alaska a few years ago. Here's a glacier. That glacier in 2005 went all the way to here. So it's kind of like a pain or an ache that you might have anywhere in your body. The longer that you ignore it and don't take a look at and check into what's going on, the worse it can become. So there's one of your choices. You ignore it. A second choice is altering it with medications, injections, or surgery, and there is a place for that. And oftentimes, some medication will be helpful as you work through the pain. Injections and surgery are usually we want to try to handle it first by coming into physical therapy to figure out what's going on and what can we do here to help it. And we usually know after a while, like, we're just not getting anywhere. I think you really need a shot. And then we usually couple it with physical therapy because then we can re-educate your body on how to function. Surgery is, of course, needed when there's some significant neurological issues going on. And both doctors, surgeons, and therapists know when that needs to be done, and we send you on your way. What do we do in physical therapy? Well, we talked a little bit about it. One of the things we do with our hands, we call that manual therapy. Remember we talked about with all the skeletal issues, particularly that first rib, or a little rotation in the neck or the upper back. That's where we get, so our joints have what we call joint play. And so we're really reestablishing full joint play in the joint so you can move through all of them. So if you look, I think you can see my hand here. Hold on a second. Let me see. Oh, there we go. So if I move my finger up, I can't move it naturally, but there's some give in there, okay? So we want to see that in every joint in your body. And so that's what we're doing when we're mobilizing those joints is to get the optimal joint play in there. We work on the soft tissues to make sure there's no restrictions there. And we do some of the non-traditional, which is a little bit more gentle, and a little bit more traditional, which might be a little more aggressive. I'm going to come back to education. Then we give you some strengthening educate exercises, particularly for your core, and mobility and stability. So we're going to work on improving your mobility in all of your joints, and then some balance exercises, getting everything working together. And then neuromuscular reeducation is where we get the whole body working together. And then I would say our biggest role as physical therapists is educating you on how to take care of yourself. So we're going to teach you how to sit, how to stand. Now, how many of you ever were taught how to do any of this, right? You go to school, let's say you're in college and you're getting a business degree. They don't tell you how to sit all day long in front of a computer and take care of your body. When I went to school for physical therapy, we were taught how to use our body to help you so we don't get hurt. Nurses have to do that as well. I mean, so we really learn how to sit and stand and walk, and then we learn what is optimal standing, what is optimal walking, and so we help you learn how to do that more optimally. And I more than once I have heard my 70-plus-year-old people like, gosh, I've been walking for 70 years and now I got to learn how to walk again. Um, you know, because your bodies are different, and so we have to teach you how to do that, how to move through transition, going from sit to stand, how to get in and out of bed. Sleeping positions, that's a big one. Sometimes it's the pillow, sometimes it's the mattress, sometimes it's the way you sleep. I think I got I think I got some tips later on about sleeping. And we'll talk about posture, lifting, and then of course any activities that you like to do, so you don't keep aggravating the area. One of the tools that I love to use here in the clinic now, I added this in about 5, 6 years ago. This is called an OOV. It works your body three-dimensionally so you can't compensate or cheat. And it gets your core activated subconsciously like it should as you function throughout the day. So here I can have someone on their back. Here's an older gentleman where I have it between the wall and his back. And again, here's an older person stepping over it. Here's my son doing a much more advanced activity where he's on one leg and doing an activity up here to really challenge his core. But I don't have pictures of it, but I have people on their stomach, on their side. You can kneel on it. We can do a plank. There's all sorts of things we can do with this, which really helps promote your core to work the way it's supposed to. The doctor who created the OOV also created this balance sit, and this is a device to sit on to activate your core as well. So, what are some tips that you can do at home? We really like you to come in. I don't like to give out exercises because everybody's different. There are other diagnoses that we have to take into account on what to give you. But there are tips which are in my ebook on the mindful movement. But here's some stuff that everybody can do. So sleeping on your side or your back, and make sure if you're on your side or your back that the pillow takes up the full space there so it remains in neutral. You don't want your head side bent and you don't want it rotated. Uh, Movement. I teach people, instead of coming in and teaching you how to mobilize your neck, I have you mobilize from down below. So even you could even do this just sitting and rotating here. You can side bend. Okay. Particularly if that neck feels really locked up, just kind of turning your body here from down below. I have people do it in sitting or standing. You can always use ice or heat. and some core strengthening exercises. So those of you who are at home a lot, or are retired, or don't get out as much, make sure you get up every 60 to 90 minutes and walk around the house. Those of you who sit at a desk all day long, get up and move every hour or so. That will make a big difference. And get my ebook to learn some more tips. If you have any questions, email me, or actually better yet, while you're here, put it in the chat box. On my website, or if you get this PowerPoint from me, this is a link to a blog post and some more information on your neck pain. Okay. And if you'd like to just talk about your issues, if you want, you can give us a call and my admin will set up a time for a phone call and we can discuss what's going on. Otherwise, if you're having a problem, let your doctor know. If you have Medicare, the doctor does need to know to write a prescription. If you do not have Medicare, you can come in without a prescription. Okay, I'm going to stop sharing this. Okay, let's see in the chat box. Okay, there are no questions in the chat box. Anybody have any questions? You can maybe unmute yourself if you have a question. No?
Denise, I have a question.
Okay.
So, when you mentioned folks with like asthma or COPD using those, I think you call them accessory muscles.
Yeah.
Um, so would that help them? I know like with their core, but more so like um exercises like trying to breathe from their diaphragm. Are there exercises like that?
Yeah, a lot of that is bringing education to the diaphragm. And that's something I didn't mention with that OOV and the balance sit. That really helps promote diaphragm breathing.
Oh, great.
So that has been the biggest thing for that. In fact, my 82-year mother, I have her, she lays on it every morning on her stomach because it helps, it compresses her abdomen, so it forces her to breathe into it.
Oh,
So that's made a big difference. And when I call these accessory muscles, each of these muscles actually have an official name, but when people breathe through there, we say that they're using those muscles because those are like secondary muscles to use for breathing.
sure.
So yeah, anything to promote that diaphragm is very important.
Okay.
You
Thank you.
can maybe hold a ball against your abdomen and kind of
Uh-huh.
breathe into that to give you some
Okay.
feedback. And
Okay.
usually I start with people laying on their back and bending bend your knees up, laying on your back, like if you're going to do a bridge,
Mhm.
um, because that's easier than sitting or standing and breathing the right way.
Yeah. Oh, great. Thank you. And if anybody wants to ask questions, I can relay them to Denise in the chat if you don't want to ask.
Well, thank you for having me. I think Amy will update you on next month, although we haven't decided what I'm doing next month.
Yeah, yeah. Well, thank you so much, Denise. I learned a
Well,
lot. It was
thank you.
really informative. And thank you so much, everybody, for tuning in. Denise's next talk will be towards the end of February. It's going to be on a Thursday. I believe it's the 20th. And it's going to be here again at 12 p.m. So take a look on our website. We'll have that up there shortly. And then in the meantime, if you have, again, any questions for Denise, feel free to visit her website. It's themanualtouch.com, and we'll send out her contact information as well. But with that, I think we'll say thank you and Happy New Year to everybody.
Thank you, everyone. Have a good day. Enjoy the sunshine.
Yes. Bye-bye. Thank you.
Bye.